Beautiful. All right, and I'll just share my screen. Welcome everybody to the August JVS Journal Club. We're thrilled to have so many people here, and that just stopped sharing. So we'll do that one more time. This month, where our event is being hosted by the University of Alabama and also by Stony Brook. And we're thrilled to have our guests here. We have two exceptional articles, and we have a lot of author guests that are joining us as well. So we'll be talking about the natural history and growth rates of isolated common iliac artery aneurysms. And Sean Steinberg and Chris Smolik are here, and hopefully Sean Leiden was also going to be able to make it. And then we'll have from our second paper is center volumes is associated with diminished failure to rescue and improved outcomes following elective open aortic aneurysm repair. And Sal Scully is here, as well as Dave Stone and their statistician, Dan Neal. So we'll introduce everybody from UAB. Mr. Bowtie himself, Dr. Benjamin Pierce, is here joining us, dressed the part, of course, and his third-year resident, Dr. Adam Banks. From Stony Brook Medicine, Dr. Lucy Price, who is an assistant professor of surgery and faculty there, as well as her fourth-year resident, Dr. Gutierrez. He's an integrated fourth-year resident. I think I mentioned that. So, again, author guests from the Cleveland Clinic, Christopher Smolik, who is a staff surgeon and quality improvement officer, Dr. Sean Leiden, the chair and department chair, or sorry, the Department of Vascular Surgery chair, and also Sean Steinberg, who is a vascular faculty there. Again, David Stone, professor at Dartmouth Hitchcock Medical Center, and Dr. Sal Scully, who is at the University of Florida, and their statistician, who you can see in the middle there, chief statistician and analytic director at the University of Florida as well, Dan Neal. This month, we are thrilled to have our guests that are reviewing and moderating. This month, we've chose to do something a little different. Dr. Maggie Arnold, who is the program director of general surgery at MedStar, has invited some of her residents to help moderate. And so we'll have a faculty moderator, which is Dr. Maggie Arnold, and we will have, I think, 3 residents, Dr. Wynn Kawaji, Caitlin Dunphy, and I think there was one more, which was Dr. Yang. So they will be joining us to moderate. Just a few little housekeeping notes. Just please stay muted. If you have some questions, put them in the chat. We'll encourage you to do that as we can address the authors and ask them to go over the questions. This event is being recorded for on-demand access, and then we'll have the September dates up, just finalizing a couple of details there, and also finalizing the October, December moderators. So I will stop sharing my screen, and we will get started with our first presentation.
Howdy, y'all. Can y'all see it without the presenter?
Swap screens for us.
Okay, let me, I think there's a better way to do that. Worked last night when I clicked on that thing. Let's see. Is that one better?
Nope.
Same thing. Okay, well, then we can fix that. We'll escape out of that, and we'll use the non-presenter view. All right. This is why we practice, right? So we can screw it up the night of the performance. So we actually touched a little bit on this, I think, at the last journal club. Pelvic revascularization is something that's a real interest of mine and at our institution, because it has a lot of impact on our patients. I just threw this in here because we have been on the Gore Branch trial, and we've written on this. I think it's worth noting before we get into the specifics of this paper, which Adam is going to run down for us. We actually know a fair bit about what happens when you have associated iliac aneurysms, when you have aortic aneurysm disease. And so I think to set up the specifics and the nuances of this paper, it's worth just reviewing this. We know that about 20 to 30% of patients who present for EVAR actually have some component of an iliac aneurysm found at the time of their presence. And quite frankly, an iliac aneurysm along with the disease is a marker of a higher disease burden in a sicker patient. They have higher ASA scores. They're usually more likely to be deemed unfit for surgery. And they tend to have worse anatomic features for EVAR, including larger size of the aortic aneurysm presentation, more proximal neck problems, and more tortuosity. But the size of the iliac does matter. And it matters really because it can be a high mode of failure for EVAR. When you have an iliac aneurysm, you're pretty much out of the IFU for a standard EVAR. When you have a common iliac aneurysm greater than 20 millimeters in size, there's more failure. When you can't fixate in the iliacs, you actually have more proximal seal problems and more migration in those cases. And when you have to land in the external, you actually have an increased rate of reintervention, as well as a long-term increase in aneurysm-related mortality. And these are all shown in prior studies. When we didn't have much to do about it, we would just coil and cover and move along. But like a lot of things, as we have more options to treat and better means to treat, we get more interested in the disease process. And so when it comes to preservation of the iliac arteries and the aneurysm repair, we know that sacrificing the hypogastric can be a pretty devastating complication, the most common being buttock claudication, but sexual dysfunction, especially if you cover both hypogastrics, the patient has disease in both arteries. Colonic ischemia or necrosis of the buttock and perineum can be seen. And I think really important is a lot of these patients are living longer as we become better doctors, and with the better use of statins and other therapies, a lot of these patients will progress their aneurysm disease and may need a more proximal repair in the future, and preserving the hypogastric artery and aneurysm repair sets them up better to have less risk of spinal cord injury in the future. So we need more than just the audacity of hope of plugging and covering, obviously. When it comes to this particular paper, the Gore iliac branch device is the only current endo, but I think it's worth noting when we look at this paper and we think about how we're going to fix these aneurysms, if they should be fixed, which is what this paper is going to help us to understand. I'll just point out that it's an off-label use, so to use the IBE alone for these cases. It actually is on label if you use the aortic component, and that's because they know a lot more about the fixation and long-term stability of the repair. But using it in isolated fashion, as seen in this paper, is not on IFU. That being said, it is technically very feasible and very easy on the patients. In this well-selected group of a small group of patients, there was a high technical success and 100% 1-year freedom from aneurysm-related mortality. But I think what this paper is going to tell us is, just because we can do something, that eternal question of vascular surgery is, should we be doing it? And with that, I'd like to turn the screen over to Dr. Adam Banks, who we are very fortunate to have kept at Alabama. He's actually born and raised in Birmingham. In fact, his father delivered several of my partner's children. And then we get the pleasure of training him now. He is absolutely one of the best integrated residents in the country. And I'm so grateful that he's going to join us tonight. Actually, he's at a VA quality course right now in Houston, so he's presenting from his hotel room. Adam, take it away, bud.
Yes, sir. Thank you. I'm going to try to get my screen shared here. Are you all able to see that okay?
Looks good.
All right. Good evening, everyone. Thank you, Dr. Pierce, for that introduction. Also, thank you to the SVS. I really appreciate the opportunity to get to present tonight at Journal Club. Again, I'm Adam Banks. I'm one of the PGY3s at UAB. I'm currently on research, presenting along with Dr. Pierce tonight. We are presenting an article that is in press for publication, JVS. It's the natural history and growth rates of isolated common iliac artery aneurysms from our colleagues at the Cleveland Clinic. So briefly, an introduction. The prevalence, isolated common iliac artery aneurysms are rare, with a prevalence of about 2% in the general population, and they're responsible for about 7% of aortoiliac aneurysms. Given the rarity of these aneurysms, 70 to 90% of all iliac artery aneurysms are involving the common iliac artery, with the remainder involving the internal and more rarely the external. About 50 to 65% of these are bilateral disease, and up to 33% are ruptured at time of initial presentation and are associated with high mortality. Given the rarity of these aneurysms, there's limited guidelines on imaging surveillance after diagnosis in asymptomatic non-ruptured common iliac artery aneurysms. This paper aimed to address that, given the limited available literature. They sought to determine optimal surveillance intervals, better understand aneurysm expansion rates, and further elucidate the natural history of isolated asymptomatic common iliac artery aneurysms through a retrospective review at a high volume center. So again, they decided to conduct a single center retrospective review focusing on about 12 years of available data. They utilized their ultrasound database identifying common iliac artery aneurysms diagnosed from January of 2008 to February of 2020. They then used the electronic health record to identify remaining common iliac artery aneurysms identified on CT scans. All of these that were associated with AAAs or previous AAA repair were excluded, and they did not have any symptomatic or ruptured aneurysms included in the study. They identified a total of 167 patients and identified 244 common iliac artery aneurysms. There were about 46% of these were bilateral disease. The mean follow-up was 62 plus or minus 40 months. They then ran two models, one to determine the change in vessel diameter per year, and another to measure the change in vessel diameter per year based on previous measurements. During that model, they did exclude two patients due to rapid expansion in large common iliac artery aneurysms, and we'll discuss that a little bit later. Overall, Table 1 demonstrates just the patient demographics and medical history. Overall, the cohort was primarily male at 94% and Caucasian at 91%. Concomitant aneurysmal disease were noted in about 6.6% of patients. These included thoracic aortic aneurysms, as well as visceral and popliteal artery aneurysms. Only one patient was identified who had a common connective tissue disorder, and that was a Marfan's patient. And a little over half of the patients in the cohort were either former smokers or current smokers at the time of diagnosis. Table 2 demonstrates the total number of common iliac artery aneurysms by sidedness that were identified by CT or ultrasound, the size at initial imaging, as well as the follow-up interval. Of the 244 isolated common iliac artery aneurysms, 124 involved the right and 120 involved the left, and it's about split equally. The average size was 2.3 centimeters, and that was similar across sidedness. Approximately 2/3 of the patients with common iliac artery aneurysms were identified through ultrasound, with the remainder identified by CT, and a little over half were followed by a combination of CT and duplex, with the remainder followed simply by duplex surveillance imaging. Table 3 demonstrates the outcomes data of the cohort. Throughout this study, no patient experienced iliac artery rupture, and all remained asymptomatic. About 11.4% of the patients required operative repair of their isolated common iliac artery aneurysms. The overall size of repair was about 3.3 centimeters, and the indications for repair included the size of the aneurysm, the saccular morphology of the aneurysm, as well as concomitant aortoiliac occlusive disease requiring treatment. On average, the infusiform morphology, the average size of repair was 3.7 and saccular was 2.3. The largest in the cohort to be repaired was 6.8 centimeters, and the average time from imaging to repair was 65 plus or minus 47 months. And tables 4 and 5 demonstrate the annual changes in isolated common iliac artery aneurysms. Overall, the common iliac artery aneurysms have an expansion rate of about 0.04 centimeters overall, and that's in table 4, which is the unadjusted group. A subgroup analysis was then performed looking at growth rates associated with different aneurysm sizes, and as size increases, the rate of expansion does increase significantly, with common iliac artery aneurysms greater than 3 centimeters were associated with a 0.13 centimeter change annually. The analysis was repeated, and those values are shown in table 5, and this was after the exclusion of two extreme data points. That analysis was shown to basically bring the all common iliac artery aneurysms expansion rate down to 0.03, and those that were greater or equal to 3 were down to 0.05. All values remained significant, and those that were greater than equal to 3 centimeters were still greater than twice that of those who were 2 to 2.5 centimeters. The two extreme values were two patients who had common iliac artery aneurysms that were greater than 6 centimeters. They were initially seen to have them around 3 centimeters, and they were lost to follow-up for several years. And upon return, they were found to have aneurysms greater than 6 centimeters, and one had an expansion rate of around 0.6, and the other with one of a little over 1 centimeter annually. They also looked at the overall infrarenal abdominal aorta and its expansion rate over annually, and they saw that to be about 0.06 centimeters per year, and that was overall. These are the major points from the study that we saw in the description of the study previously that we've discussed on the previous slides. In a brief discussion, this study, in this particular study, iliac artery aneurysms were shown to be slow growing with expansion rates of less than 1 millimeter compared to prior results demonstrating 1 to 4 millimeter growth annually. The occurrence of ruptured common iliac artery aneurysms under 4 centimeters is rare in the current literature, and current recommendations are to consider elective repair at 3.5 centimeters, some studies advocating for waiting until 4. The current guidelines from the European Society for Vascular Surgery advocate surveillance imaging every 3 years for aneurysms at 2 to 2.9 centimeters, and then annually for those 3 to 3.4. The authors of the manuscript put together their recommendations within the text. This is just organized into a figure. Basically, they recommended that a common iliac artery aneurysm identified on imaging, that patient should undergo CT angiography to look at the entire aorta iliac system to rule out any concomitant aortic degeneration associated with the iliac disease. At any size, they then recommend re-imaging at 1 year to rule out any rapid expansion as seen in some of the patients, the 2 patients described in this study. They then recommend that for each size increment that's shown here, that surveillance be increased. So from 2 to 2.5, a 3-year surveillance, a 2-year surveillance for 2.5 to 2.9, and then 1 year for 2.9 up to 3.5, and then a consideration for elective repair at greater than or equal to 3.5 centimeters. One of the interesting points was repeating aortic imaging with CT angiogram at 5 years, basically because of them showing that there was a 0.06 centimeter change in the infrarenal aorta as well associated with these aneurysms. So limitations and future directions. Overall, I think this is a well-done article that is investigating an important area of research regarding aneurysmal disease processes and natural history that are not well defined. They did mention several of these in the paper, but overall, there was some concern for any inadequate capture of patients within the ultrasound library or depending on health record accuracy. Retrospective design is also a limitation, but as far as a main point here, those limitation to non-ruptured and asymptomatic common iliac artery aneurysms. And given that the natural history discusses that there is up to 33% of patients do present with ruptured or symptomatic common iliac artery aneurysms, I think an interesting continued investigation into patients who presented within this same time frame and time interval during the study. How many were repaired? What was the morphology at repair, and what was the size of the aneurysms at repair? I think that would further assist in determining if the disease process is as benign as it seems. Otherwise, I think there can be further investigation into bilateral disease. We can determine reasons for rapid expansion in selected patients and develop a standardized protocol for management as shown in this particular article. I also think, despite that there's a high prevalence in men, I think the gender differences in the aneurysms would be a good place to look as well, given that there are differences in other aneurysmal processes. Thank you, and I open the floor to discussion.
Thank you, Dr. Banks. I really appreciate it. As you're stopping to share your screen, we'll let Dr. Arnold and her residents come on. There are some questions in the chat. Please add more questions to the chat as they begin the discussion and addressing the authors.
Dr. Banks, thank you so much for your elegant discussion of the paper. I'd like to introduce Dr. Kawaji, who has some questions for you.
All right. Hello, everybody. Great presentation, Dr. Pierce and Dr. Banks. And thank you, Dr. Smilock, Dr. Light, and Dr. Steinberg for being here for the discussion. For the paper that we discussed earlier, the population in the study were mostly Caucasian males. When it comes to AAA outcomes, studies have shown that gender and race play an important role in both management and outcome after repair. In your study and in your literature review, did you observe any difference between genders or any association with race in terms of management and outcome of isolated common iliac artery aneurysms?
Chris, do you or Sean want to answer that?
We didn't, I think, because, you know, I don't think we had enough to answer that question. It's always something that's in our mind, but we did not see that in our study. I don't think we had enough. to answer that.
Anecdotally, Chris, this is a disease that seems to predominantly be in white males, though, right? I mean,
And I've always wondered, is that because we, you know, our bias is that we look for
them. Yeah.
in those patients. But yeah, I mean, if it follows similarly to aortic aneurysms, and you look at, you know, some of the classic VA studies and whatnot, you know, you're up in the 90% of, you know, for men. And again, I don't know if that's just the population bias or the, you know, the screening bias.
These men that have, I mean, it's almost always men that have these sort of large common acts, and a lot of times common in internal. I know that's mixing a little bit out of your paper. It's almost always Caucasian men in their like late 50s that I've had to operate on or done in these cases on. That's personal anecdotal experience. I think that your number is probably what it is. It's just not something we see in females or other races. With the understanding that there's bias and everything we do, I get that, but
Yeah.
but it really is the people I've operated on for this almost always are. And I think to answer one of the things in the chat, a couple people asked this, Adam, that 33% rupture, that was something you got from Rutherford's chapter that basically was saying that essentially a third of people who found out they had an iliac aneurysm found out about it when they ruptured, right? That was the
That's right. Yes,
number. And that's because there's no screening protocol, right? I mean, you're much more likely if you have one of these things to present with a rupture because nobody goes out and looks for isolated iliac aneurysms in patients. A lot of people get those lifeline screenings at the mall and find out they have an infrarenal aneurysm. And I don't have a whole lot of faith that those people are looking down in the pelvis and those sorts of things. So I think that's where that number comes from. I don't think it means that a third of all iliac aneurysms are rupturing at all. And in fact, that's what I think is important about this paper personally, is that it's proving that if found incidentally and at reasonable size, it's a pretty benign disease process. Is that how you kind of came up with all this, Chris?
Yeah, you know, we have these people who get it done for whatever reason, and I think our lab, probably like many of your labs, you know, in great centers like are represented here on the Zoom, are people looking down in the pelvis, looking at, you know, at all arteries that they can see, and they find something, and then you start following it, and you're like, why this hasn't grown for years, you know, year after year. So let's look back and see, you know, how can we find people who we've at least looked at twice, and what other imaging do they have? Do they have any CAT scans, and kind of compare this and really look at patients who do not have aortic aneurysm. So that may be the other thing with that 33%, is there some continuation, some contiguous aneurysm with the aorta and the iliac? These patients do not have that at all. Those have all been, even small 3.5 centimeter aneurysms, they've all been excluded from this, to really see what do these isolated, you know, aneurysms mean. And I think, yeah, I think it's a pretty benign process. I just want to make sure I'm hoping I'm not missing anybody else's questions here.
Well, we can go through some of the questions in the chat. You know, Carlos Becerra is asking about patients with diabetes. Did you notice that they had a lower rate of expansion?
Honestly, I don't recall that I don't think Sean Steenberg is on the call, but no, we did not look at that, Carlos, and I didn't notice that, but I mean, if it would be interesting to see if that holds true, like we know it does with aortic aneurysms. The COVID thing is interesting, and you know, and I feel like I haven't seen this necessarily with iliacs, but I feel like there seems like there's a lot of activity on the mural thrombus. And I think, you know, a lot of that we've seen with quote unquote symptomatic aneurysms that are small in other places in the body. So that's an interesting question from the University of Arizona.
Another question that I had was, aside from the other comorbidities associated with the increasing growth rates, aside from size, 11 of the patients in the study had concomitant non-AAA aneurysmal disease. Did these patients have the same growth rates as patients who didn't have these disease? And there were also 2 patients you mentioned that had exceedingly fast growth common iliac aneurysms. Did these patients have connective tissue disorders? And I think there was 1 patient of the entire study population that had Marfan's. Any thoughts on why these patients had such fast growth rates?
Those 2 rapid ones, no, not necessarily. Not necessarily collagen disorder, or the other thing you would think about there, at least I would think about, would be something infectious. We didn't see that there either. They just kind of seem to be outliers, but they could certainly have some, genetic predisposition that we just don't know about yet. And it seemed to me, that just also anecdotally seeing a lot of these patients that have kind of larger externals and then tend to have larger femorals and larger, popliteals, it almost seems like a phenotype that's not that well described yet. So I'm sure that there's something with that somewhere. We just don't know yet.
Thank you.
They also asked about other factors that you really identified for rapid growth. And you mentioned a couple of things, but I was wondering if you could expand on a little bit more of that.
Factors for rapid growth?
Did you identify any associated factors, or did you look at what factors were associated with rapid growth?
No, we didn't have that many patients who did grow rapidly, so we couldn't really look at that, I don't think, very easily. But yeah, I know that 4 centimeter, I'm seeing, pop up here that 4 centimeters is being kicked around as a new, and it certainly seems reasonable. We had kind of decided as a group years ago to do 3.5, and I think a lot of people were doing 3, and that, again, that's just anecdotally. Now, Dr. Forbes asked about open RP anterior. I think, personally, I've done all, even from the right side. If there's a place where you can kind of get there and get around the vein on the right, I've still done them if there's a place to clamp a non-aneurysmal part of the common and do it that way. So I think it just depends on what we see, what's easier to clamp, what's easier to get to.
Other questions before we move on to the next article? It's a lot of great discussion about, I think size criteria here are really needed. In some places I hear about people wanting to repair them at 2 or 2.5 and not necessarily letting them go on to be something a little bit bigger. Thank you, Dr. Smolik. We appreciate it. And we have one more question that just kind of popped in, is how do you define rapidly enlarging aneurysms for diameters less than 3.5 to 4?
Yeah, good question. Not sure. I mean, I think those 2 outliers that grew rapidly were so, were beyond even what we consider for aortic aneurysms, inframenal aortic aneurysms, at least, a centimeter a year or 0.5 centimeter per 6 months. So that was easy. But I don't know that we know enough or have seen enough grow rapidly other than those other 2 to actually be able to say that.
Wonderful. Well, thank you again for being here and your team for this wonderful work. We're going to move to our next paper, and the Stony Brook team will be presenting and discussing this. Dr. Price, do you want to get started?
Yes. Okay. Can you all see my presentation, or is it in presenter mode?
Swap your screens.
Okay, I think I'm going to have to end up doing what Dr. Pierce did.
You go under display settings, it should say swap your screen, and then if you just flip it, it should work out. So
I don't even know where that is.
when you go back into it, so go into the presentation like you had it.
Mm-hmm. Yeah, I'm there.
No, you have to put it back up on the screen.
Oh, I see.
Yeah.
Mhm. One sec.
So act like you're giving the presentation. So hit start presentation.
Yes.
Perfect. Under display settings
One
on the
second.
left side, right next to end slideshow,
Oh, I see.
Yeah.
Ah, there you go.
swap your screen. There you go.
That work?
We all are learning today.
Okay. All right. Well, I appreciate that lesson. With that being said, good evening, everyone. I'm Lucy Price. I'm one of the vascular attendings over at Stony Brook. I'd like to thank JVS, SBS for the opportunity for us to present. So far, it's been a fantastic conversation, so I'm looking forward to keeping that going. All right, so we're going to switch from common iliac artery aneurysms to kind of quality of care in aortic surgery. So why are we talking about this topic? Well, the trends in aortic surgery have changed quite drastically within the last 2 to 3 decades. In this paper from the Dartmouth, published in 2018, where they looked at observational cohorts. This is an observational cohort study of Medicare patients. And so what we can see is that while EVAR has actually recently slightly declined due to the advent of branched and fenestrated EVAR, the number of open abdominal aortic aneurysms has fallen to nearly 80% of the original back in 2003. So when comparing a practice with the region that had the highest volume of open abdominal aortic aneurysm repair in 2013, this would actually, that number would be quantified as the lowest 20th percentile in 2003. So there's been quite a significant change in the way and the type of aortic pathology being treated. The authors then further delineated between open and EVAR, and you can see the quite drastic change in the color scheme, almost the inverse from the left to the right. And so with the changing climate of aortic surgery, how do we work towards obtaining the best outcome for our patients? And so the group at University of Florida, Dr. Scully, published this paper. Center volume is associated with diminished failure to rescue and improved outcomes following elective open abdominal aortic aneurysm care, which will add to our current understanding of treating these patients. So as we know, factors that influence our patients' outcomes within vascular disease is not only multifactorial, but also multidimensional. So within the disease process itself, there's a magnitude of variables that affect the patient's overall outcome. And as we go one step kind of further, we look at patient level factors, and we know very well that any of these factors will also affect the patient's outcome. So in a retrospective review of a nationwide inpatient sample database from 2007 to 2011, Hicks et al. Demonstrated that aside from the operative approach, intrinsic patient factors were most strongly associated with in-hospital death following an open abdominal aortic aneurysm repair. We take one step farther out and we look at hospital level factors. We also see that, where you are, where you practice, what you have available will also affect your patient's outcome. It's also important to note, particularly with case volume and surgeon volume, those are often also, those numbers we have to look quite discerningly. So depending on if you're practicing in a place that is very, endo aggressive, well, the cases that they may be doing open are maybe decreased in number, and they may also have increased complexity, whereas patients who or individuals, practitioners who work in a center that's less aggressive endovascularly, well, they may have more open cases, have less complex open cases, and therefore may have better results. So we kind of have to take these numbers also and look at them discerningly. That being said, in the same study that I just mentioned with Hicks et al., they demonstrated that outcomes for open aortic aneurysm repair were better among hospitals performing at least 25% of their abdominal aortic aneurysm repair using the open technique. So this is kind of keeping in line with a lot of the standard guidelines that hospital volume does have a moderate effect on patient mortality, even after adjusting for patient level differences between institutions. We take it one step farther, societal factors. So access to medical care, insurance status, practice guidelines, all of these impact what kind of outcomes our patients have because it influences what we can and cannot do, what we can get approved. And as mentioned in the Iliac conversation we just had, it is also going to affect the size parameters that we use in offering our patients treatment. So for example, the SBS published their guidelines on abdominal aortic aneurysm disease in 2018, specifically looking at open abdominal aortic aneurysm repair. And they recommended that centers that do this procedure should have an annual volume of at least 10 open aortic operations with a documented perioperative mortality of 5% or less. That being said, the level recommendation is weak. So I keep throwing around the word quality. So what does that actually mean? So the Institute of Medicine defines it as the degree to which healthcare services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. They then further broke this up into 6 domains, which when we're looking at quality for our patients, we can look into each of these in order to provide the most optimal care for them. Why do we care about quality metrics? Well, we want to optimize our patients' outcomes and our patient care. That's first and foremost. We can look at our own parameters, see what's successful, what's less successful, implement quality improvement plans, develop practice guidelines. These metrics are also used in terms of certification and credentialing, and patients are now having access to these metrics. So these are becoming increasingly important for us. So there are quality improvement databases that have emerged, and for the vascular surgeon, we know these names all too well. So the SBS has the Vascular Quality Initiative. The American College of Surgeons has a National Surgical Quality Improvement Program, NSQIP. So with SBS BQI, the collaborative, they're looking at preoperative risk factors, intraprocedural variables, post-procedural outcomes, and they look at 14 different vascular procedures. It's a collaborative effort. As a result, we have cardiology, interventional radiology that also add to our current database. And it's very good because it has more intraoperative nuances for the vascular surgeon to look at and analyze. NSQIP also collects demographics and allows us to look at these quality assessment parameters that I've listed here. And then there are other quality metrics that we can look at: patient-oriented outcomes, indirect measures of quality, hospital volume, and surgeon volume. And it's important to note that no single quality metric here is fulfills all operations or procedures. So it's really important to kind of look at what you're studying in order to get the best information possible. With that being said, composite outcome metrics have emerged, and this paper uses one of those. So when you're thinking of, when you're looking at hospitals, they can oftentimes have, it can be difficult to interpret observed variations in outcomes between hospitals. What does that mean? So if there's some statistical uncertainties that are present if you have a low hospital volume and a low event rate. We're talking about open abdominal aortic aneurysm repair, and we're going to be seeing numbers that are relatively low. And so mortality is dependent on not only a case mix, but also hospital performance. So these composite outcome metrics have been created because they're less sensitive to risk adjustment errors. One of them that we're going to be talking about is failure to rescue. So what is failure to rescue? It represents the ability to treat complications effectively and therefore prevent death. So the definition is in-hospital death after a patient has experienced a complication. So FTR reflects an overall team and hospital performance. So mortality, as we mentioned, is dependent on the type of admission, on operative setting. So that number can be very variable. However, the ability to recognize and treat complications and avoid death is unrelated to the type of admission, the operative setting, and as a result, you can use that to make more comparisons if you wanted to compare elective versus emergent, for example. Limitations of failure to rescue. Well, it's at the end of the day, it's a fraction. So it's dependent on the number of major complications related to the overall hospital volume and the death rate. Complications must be identified, they must be captured in order to be able to use this metric. As we know, complications are often underreported, and complications evaluated must be the same for comparisons to be made. So you can't necessarily compare an FDR in one study to an FTR in a different study, because it's really dependent on what complications were assessed. And the assumption is death is preventable. And unfortunately, we know that that's not always the case. There's an influence of age, so younger patients may be more resilient and as a result may have a better outcome than someone with the same complication at an older rate. And then short time frame assessed, oftentimes this is within their hospitalization and not necessarily longitudinal information that's being assessed. So with that being said, I'm going to present Dr. Gutierrez to talk about this paper in more detail, and I look forward to the conversation.
Good evening, everybody. Can you see my screen?
I cannot. And now I can.
Good.
Perfect.
Right. Thanks everyone for joining and letting me present. Thanks to JVS and SVS and Dr. Price for the introduction. The title of my talk, or not my talk, but the paper that is being presented today is Center Volume is Associated with Diminished Failure to Rescue and Improved Outcomes Following Elective Open Abdominal Aortic Cases, Aortic Aneurysm Repairs out of University of Florida. So to start with the methods, it was a retrospective analysis of a prospectively collected national registry data from the VQI of elective open aortic cases. The study population included all patients who had undergone open aortic cases from 2003 to 2020, which included all elective infrarenal and juxtarenal open aortic cases, and excluding any thoracoabdominal or suprarenal aneurysms. In addition, cases that were excluded were cases that were non-elective, whether they were symptomatic, intact, ruptured aortas, missing data, cases that were performed on the weekends, data that was missing any urgency, data from it, centers that were only having 1 cases per year, and cases that had patients less than 18 years of age. So in total, the total cohort was 9,791 elective open aortic cases, elective cases. The primary endpoints that the paper was aiming for was to assess the association between annual center volume and the incidence of failure to rescue after elective open aortic repair, as well as determining which factors were associated with failure to rescue. The secondary endpoint that they tried to elucidate was looking at specific complications that were predictors of failure to rescue. Looking at some of the definitions that Dr. Price talked about earlier in the introduction, as well as some additional background information, the paper defined failure to rescue as any in-hospital death that had occurred after one of any 6 major complications, including colonic or bowel ischemia, return to operating room for bleeding, renal, pulmonary, cardiac, and stroke-related morbidities, as well as annual center volume was defined as a mean annual number of open elective and non-elective open aortic cases across all the years of the VQI membership. These centers were then kind of categorized into quartiles based on annual open volume. So the Q1 quartile was less than or equal to 3 cases per year, whereas Q2 quartile was 4 to 6 cases per year. Q3 was 7 to 10 procedures per year, and Q4, which is the high volume centers, were centers that had greater than 10 cases per year. Jumping into the results, Table 1 essentially assessed differences in the patient and procedure-related factors stratified by whether FTR had occurred. A total of 9,791 elective open aortic repairs were analyzed. Essentially 3,176 had at least one post-op in-hospital complication. Failure to rescue events occurred in 302 of these 3,000 patients. Looking at specifically patient-related factors such as older age, woman, patient with higher comorbidity burden based on ACA score, larger AAA diameter, and any prior history of aortic repair were all significantly more likely to experience higher rates of FTR. Procedure-related factors, again, these specific factors, looking to variables associated with procedure-related factors, we can see how operative complexity such as EVAR conversions, concomitant bypass, whether it's renal or lower extremity bypasses or any additional procedures such as suprarenal aortic cross clamping were associated with higher rates of FTR. In addition, epidural use was lower in the FTR group, as well as there was a higher use of autologous transfusions in the FTR group as well. Looking at table 2, it's set to answer if there were any differences in patients or operative factors across the different categorized centers volume quartiles. Looking specifically at patient factors, and what they saw was that there were no differences in age, sex, aneurysm diameter, or any comorbidities across these center quartiles. But what was seen was higher volume centers were less likely to perform elective open aortic repair on non-white patients and more likely to treat patients with higher BMIs. Looking at the procedure factors in this group, epidural use was higher in the higher center volumes, and case complexity based on concomitant thrombectomy, whether it's leg bypass or any concomitant procedure, were lower in the higher volume centers. Looking at figure 1A, which looked at the crude non-risk adjusted association between annual center open abdominal aortic repair volume and failure to rescue rate. The y-axis being the failure to rescue rate and x-axis being the annual open repair numbers. What we can see is based on the graph is that the center volume is inversely associated with the FTR rate. For each additional 5 open aortic repair per year a center performed, there was a decrease in about 9% in FTR. Also, about 73% of the VQI centers performed less than 10% of all open aortic cases per year, which accounted to about 32% of all elective open aortic repairs nationally. Next, looking at figure 1B, this inverse relationship was similarly seen when centers were categorized by volume quartiles. Hospitals in higher volume quartiles had lower FTR rates. Figure 2 represents risk-adjusted outcomes for demographics, comorbidities, and procedure-related factors, with the forest plot representing odds of failure to rescue that's stratified by annual volume quartile. The forest plot reveals that we see an increase in quartile, essentially increase in operative volume, our odds of FTR is decreased. If you look at specifically Q1 and Q2 quartiles, they essentially lay on the line of no effect. And as we move up in the quartile in Q3, there is a decrease in the odds ratio, although the confidence interval does cross the line of no effect. Moving down to Q4 quartile, patients who had undergone elective open aortic cases in centers that had done more than 10 per year on average had almost a 50% reduction in predictive risk of FTR compared to lower volume institutions. And figure 3 is set to look at significant differences of specific types of postoperative complications and the predictive FTR risk associated with these complications. Renal complications carry the lowest risk of failure to rescue. They're followed by cardiac complications, resulting in roughly a 3-fold greater risk of failure to rescue. And when looking at stroke, pulmonary, and bowel ischemia, these respectively resulted in 4, 5, and 6-fold increase in failure to rescue, with return to OR for operative bleeding being associated with the highest increased risk of FTR, which was about 12-fold increased risk. So in summary, this paper showed that there was a strong inverse correlation between the incidence of failure to rescue and the annual open aortic repair procedure volume, with the high volume centers being greater than 10 open cases having the lowest incidence of failure to rescue. They also showed that for each additional 5 open cases per year that a center performed, they can reduce this risk by approximately 9%. Again, currently greater than 70% of VQI centers perform less than 10 open aortic cases annually, and thus not meeting the current SVS endorsed volume threshold. And when looking at complications with the highest predictive value, bowel ischemia and return to OR for bleeding tended to be the highest risk predictive for failure to rescue, which is important when trying to mitigate these types of risk or trying to essentially mitigate the risk of these complications after they've been performed. Limitations and questions that I had was one, that this was a retrospective analysis, even though that it was prospectively acquired from the VQI registry data. One limitation, again, what I saw was that all complications were self-reported by the institutions, which can lead to underestimations of these complication rates. There was no description of whether these centers were either academic versus community or surgeon profiles, which could all influence outcomes of these types of cases. There was limited follow-up, and as well as the failure to rescue counts for mortality, but does not describe anything about morbidity. As we know, these types of cases can have extensive morbidities post-op, such as renal failure, etc. That's it. Thank you, guys.
Thank you very much, Dr. Gutierrez. This is a great review of this paper. Dr. Arnold, do you want to start us off with some of the questions and your team?
Absolutely. Great. I think, by the way, thanks. I thought that was a great paper, and I think it raises a lot of questions, and we should have some interesting discussion. Dr. Dunphy, do you want to lead us off?
Yes. Hi. Thank you, Dr. Gutierrez and Dr. Price. That was a really good presentation. One thing that I thought was that I had a question about was the number of exclusions for symptomatic or ruptured aneurysms. I feel like that number, it was a pretty high number of exclusions. I think it was like 3,200 or something around that number. And I don't know if they looked into seeing if that would change the quartile range of certain institutions. If more institutions are operating open on these symptomatic or ruptured cases, would that change their number of to put them at a certain end quartile, and would that change the numbers? I know it's easier to study in elective settings because there's sicker patients when they're symptomatic or ruptured, but I just thought that might change the numbers a lot given the number of exclusions.
The volume calculations, the volume quartiles were based on all open AAA procedures. We didn't just look at the volume of the elective open AAA. So we excluded the non-elective procedures consciously, but included them when we determined whether the center, where it fell in the volume quartiles.
Thank you.
Also, we did a whole separate paper on non-elective failure to rescue that's now in JVS. So we did a parallel paper, but also looked at EVAR, looking at non-elective EVAR and non-elective open repair and failure to rescue. So you can read that online in JVS now.
Great.
Dr. Yang?
Hi, good evening, everyone. Great presentations and great discussion so far. I did have a question just in looking at the annual OAR volume. Was there any separate analysis or plans for future analysis with maybe subgroups separating high versus low risk patients? It seems like, we kind of delineated there certain patients, larger AAA sizes, older patients. if there's any consideration for any type of future analysis, because one of my thoughts was perhaps, centers that have higher quartiles maybe have more complex patients or have patients with kind of these higher risk categories to begin with.
That's a great question. First, I think that question actually will sort of touch on some of the things I was reading quickly in the chat. It's hard to sort of see them all because they're firing off quickly. Somebody had said, we see a lot of reports like this, these volume associations. What's the take-home message? What do you do with this information? Well, to date, all of it's all about just raw center volume. It's really not talking about mechanism. And we think that failure to rescue may be part of the mechanism that explains a lot of center variation. And also, as Dr. Price pointed out, mortality rates for elective aneurysm repair, open aneurysm repair, are now between 3 and 4% in the VQI, and those mirror what's happening in Medicare beneficiaries. And so looking at crude mortality or even risk-adjusted all-cause in-hospital mortality may not be the best differentiator for quality and outcome. So that's why we went down this path to look at failure to rescue, which really hasn't been described in great detail for aneurysm repair in general, particularly when taking into account patient and procedure level factors that we all know are important. There are limitations in any VQI data set when it comes to sort of trying to do these analyses. We did not look at NSQIP, but VQI is enriched with a lot of variables that NSQIP does not have, like cross-clamp location and the aneurysm morphology. There's a lot of additional granular anatomic information that you can get from VQI that you can't from NSQIP. So that would answer one of the other questions in the chat. The issue about complications, that we were interested in trying to not only look at the volume association with failure to rescue, but really drilling down further, because not all complications are equal, as we saw in the analysis. And so it begs the question, I think the big take-home message is that over time, we actually did a temporal analysis recently that's going to be looking at sort of the practice pattern and variation over time. And over the last decade, it's not like we're shifting cases to higher volume centers. That's not happening, despite everybody ringing the bell since 1978, when the first paper came out about volume outcome relationships in surgery. Open aneurysm repair is still being done in a lot of centers that don't even meet minimum volume thresholds that are endorsed by society. Actually, 75% of the centers on average are performing less than even 10 repairs. Yet all those centers aren't doing poorly, right? And while we'd like all the aneurysms to go to high volume centers, that can't really happen in the United States. There are geographic and financial limitations. There's market problems, patient choice. There's just so many barriers that have really limited our ability to truly centralize aortic care. Yes, I'm at a high volume center. We'd love it if all the aneurysms came to UF or went down to USF or to other higher volume centers in our state. But the reality is they also get done at other hospitals that are doing less of this. And so for hospitals that continue to provide these services, how can you improve that? What can you do to mitigate that? Well, I think it's looking at these complications and sort of improving team performance. So which complications? Well, it's the ones that have the highest likelihood of subsequent death. And so those are where you have to sort of drill down, look at your own center's results. Do you have a high rate of, return to the OR for bleeding? Do you have higher rates of colonic ischemia? What is your sort of ancillary service support to adjust and treat those complications if they do arise? Are there higher risk patients that you can identify for those complications that you then implement processes of care to then sort of target those complications to mitigate their risk and then hopefully improve your ability to reduce a failure to rescue event?
Sal, do you want to just address Dr. Forbes' question here about, can you comment on the spectrum of rescue strategies for bowel ischemia and how these might be center dependent?
I 100% agree. I think it's a real limitation of the data, the registry, which was in a very erudite way put up by Dr. Price and also Gutierrez's sort of presentations. These are self-reported complications. How are you making that diagnosis? What's the severity of it? What's the threshold that you sort of, do antibiotics? Who's getting scoped, not scoped? Do you have GI services? Do you have, I think that's one of the limitations of this data set. I really can't comment on that, at least at each institution. However, you are going to sort of increase the sort of, your antenna are raised up about these patients, knowing that there's certain high-risk complications that I think that you would have to sort of focus resources on to try to reduce their risk. And if they do occur, have mechanisms where you can react very quickly. And knowing that, these patients are the most vulnerable to subsequent failure to rescue. What's also not commented on is it's this idea that complications rarely occur in isolation. Right within the paper, this is a phenomenon that's been written about, is the fact that It's you have a patient who has a complication. Now everybody's worried about this patient, and you're trying to do things, but for whatever reason, you can't stop the train. It's like the train just keeps going down, right? You're worried about the patient, complication occurs, you're doing stuff, and then the next complication occurs, and the next complication. And then this cumulative effect was actually the dose response. Patients with a single versus multiple complications had very, very different subsequent risk of failure to rescue. It's a duh moment, like, sure, you have more complications, you're more likely to die. But it's interesting that these patients are the ones that we're most interested in, and that we're putting resources in once we recognize that first complication. But then there's a cascade of events that, for whatever the reason, we're unable to sort of derail.
Well, and I want to respect everybody's time. So if you do have to leave, that's fine. But I do want you to address Carlos's question also about, some of these other places are doing 5 to 10 complex repairs versus open aortic repair. And, which, Carlos is saying does take more skill. So how do you account for this in terms of your volume?
We can't. And so the DVQI only looks at that. And so that's exactly right. And that's also in the center volume thresholds and guidelines. They only talk about aneurysm repair. They don't talk about the aorta bifems or the thoracos or, the dose response of what proportion of endo versus open. This is part of the problem with volume thresholds in general, is the lack of specificity on how you do the counting, the aggregate. Also, you can't account for the surgeon. I don't have, if I did my aneurysm repair with Dr. Humphreys every time, I'm sure my outcomes would be top notch, but you don't know who your partner is across the table. Those are never accounted for. That effect of the partner and the oversight within the practice. These are all the things that we can't measure. And the VQI can't do it, but there's no data resource that's going to tell you that you can sort of account for the center's true volume. So it's a shortcoming of these analyses.
Well, thank you everybody for being here. Lots of great discussion, just 2 really great papers, and demonstrating how we need to know more, why research is so important, and how great it is actually to have the authors here to really go over this. So Sal, and thank you for being here. Chris Smolik also, Dr. Neal, everybody for being here. Really grateful to have all the discussion. We will see you in September, and we will allow everybody to go about their night. So have a great night. We'll see you next time.
Thank you, Misty.